Conference record has joined the conference.
So a couple quick things. This is the Friday NAMI teaching call. We do our best to get America's best thinkers right directly to the NAMI membership. These calls happen twice a month on the third and fourth Friday of the month, a child and adolescent call on the third and an adult call on the fourth. We record these calls, which are available at www.nami.org/askthedoctor. And we try to cover everything under the sun. If you have ideas for things you'd like to cover, feel free to tell Emily, my teammate, or myself, either on these calls or through email. I'm Ken, K-E-N, at NAMI. And Emily, you're E-SEPLA, C-E-P-L-A?
Yes, I am.
At NAMI.org. Is the good Dr. Carlson on the call today?
I am here.
Thank you so much. So we're fortunate today to have one of the leading thinkers in pediatric and adolescent psychiatry on the call. And we're going to be discussing how some people in the APA, in the DSM committee, change some of the frameworks for how diagnosis goes in the DSM-5 from DSM-4. Obviously, on this call, we don't give medical advice, and we certainly couldn't give out a diagnosis to anyone who's on the call. But thinking about how the framework has changed is relevant. Well, we usually ask our expert to give a 15 or so minute introduction of the topic, and then we take questions. I'd ask everybody to please put your phone on *6, which is a mute, so that your barking dog and other adventitious noises don't interrupt the call. You can then hit #6 to ask a question. Dr. Carlson, I want to thank you for donating your time to NAMI, for everything you do in the field, and for joining our call today.
My pleasure.
So would you take it away about what we know about how things have changed?
Okay, so my charge was to talk about DSM-5 a little bit and its evolution, and so specifically about conditions that affect children and adolescents, or the conditions maybe that have changed. I think one of the things that's really interesting in this process is where it evolved from. The DSM stands for Diagnostic and Statistical Manual, and it actually began probably in about 1840 when the first census was used to look at mental disorders, and of course in those days they were looking at asylums, and the classification system was very simple. You had a choice of idiocy, insanity, or not. So we didn't need a very big manual for that. 40 years later, things had increased, and there were a bunch of new categories, or a bunch of other categories, which included mania, melancholia, monomania, epilepsy. So there was a combination of neurological and psychiatric conditions. It took another 40 years before the harbinger of the American Psychiatric Association, something called the Committee on Statistics, developed a new guideline for mental hospitals, and the book that came out of that was called the Statistical Manual for the Use of Institutions for the Insane. So you can see now where the DSM business was beginning to get born. Now by this time we were up to 22 diagnoses.
They'll hear it.
A sea change occurred with World War II, and that change occurred for a variety of reasons, not the least of which was that U.S. psychiatrists were involved in the selection, processing, assessment, and treatment of soldiers. So we started moving away from asylums and into the community. And at that point, it was recognized that the classification system that existed really didn't begin to cover the kinds of issues that the soldiers had. By 1949, the International Classification of Diseases, which covers all of medicine, included a section on mental disorders for the first time. And the DSM-1 had a special category now for mental disorders. And this became the background for the DSM-1, which was published in 1952. So the DSM-1, I like to look at this because it's really grown. 1952, there were 106 mental disorders and 130 pages. 1968, we're up to 182 disorders. 1980 was 265. That was DSM-3. DSM-3R, we went from 500 to 567 pages. With DSM-4, there were almost 300 disorders, and nobody dares count the number in DSM-5. They like to say that they eliminated some and combined some, but we went from 130 pages to almost 1,000 pages. The DSM has sort of reflected the zeitgeist of the time. So DSM-1 and DSM-2 reflected the predominant psychodynamic psychiatry that went on. There were some concepts that were more sort of biological, medical classification, but not terribly specific. So if World War II was the first sea change in thinking about diagnosis and who it had to apply to, the next sea change occurred in the middle 1970s. And that grew out of a couple of interesting research projects, the conclusion of which was that you could not get two psychiatrists together to look at a patient and get them to agree on what was wrong with the patient. That's not good, because if you don't have people able to agree on what they're seeing and what's important, then the diagnoses that you make don't have any degree of reliability or validity. And so as a result of the two projects that went on, one was in the United States and one was between the United States and the United Kingdom, because of that they said, well, we're going to have to be better at defining what we're talking about, and we're going to have to come up with a more systematic way of measuring what it is we're talking about. So we went from DSM-2, which was descriptive, to DSM-3 and thereafter, where a lot of time and effort was spent on developing criteria. And the criteria were basically so that we could all look at the same things, ask pretty much the same questions, identify the same things that were important as far as making a diagnosis, say, of depression or schizophrenia or whatever. You know, I'm old enough, so I was around for the evolution between DSM-2 and DSM-3, and I remember when I was a medical student making a diagnosis of schizophrenia by whether or not the patient raised the hairs on the back of your neck. Well, that's not the most reliable way of making a diagnosis that you could come up with. So, again, a lot of time was spent by the committees trying to look at the literature, look at the research, and decide what are the core features, what are the most common denominator identifiers to the particular disorder that we have, and then there was a development of a lot of various rating scales and interviews to go out and those conditions. Now, unfortunately, the original goal of the DSM back in the 1970s and early 80s was to form a manual that was supposed to be useful for research and clinicians. The fact that it's taken on political and insurance and legal and all those ramifications were never part of what was originally intended. So one of the things that the DSM has tried to do is delineate what a mental disorder is and what it isn't. And so there's a definition that reflects a dysfunction in the psychological, biological, or developmental processes underlying mental functioning. So they try to make it comprehensive. It's associated with impairment, so distress, social, occupational, or other activities being interfered with. They affect the individual's thinking, feeling, or behavior. And the hope is that the diagnosis has clinical utility. It should be helpful in terms of determining prognosis, treatment plans, potential treatment outcomes for patients. What a mental disorder is not is an expected or culturally approved response to a common stressor or loss. It is not socially deviant behavior or conflicts between individuals and society unless they result from a defined disorder. And it is not an equivalent for a need for treatment. So with that as the background, let me just talk about a few conditions where there have been some important changes for children. And those conditions are autism spectrum disorder, attention deficit disorder, oppositional defiant disorder, bipolar disorder, and disruptive mood dysregulation disorder. Now, autism has probably been that and disruptive mood dysregulation disorder have probably captured the most press. And the reason for that is because we've put autism on the map really with DSM-4 three, and with each iteration of the DSM, and believe me, I'm not necessarily defending it. I was in the DSM-4 committee, so I know the hard work that goes into it. But with each iteration, you learn stuff, and the things that you learn, you try to apply and put into the next iteration. But usually the next iteration that comes along has a different bunch of people with different goals and different mental sets and research, and so issues about how these things evolve. So with DSM-4, autism had a number of different subcategories, and these included infantile autism, which was sort of the original condition that Leo Kanner defined, Asperger's syndrome, which was supposed to be like autism without a language or intellectual delay or history thereof, but had the other issues that had to do with autism, mainly the social reciprocity problems and the circumscribed and stereotyped interests. There was a large wastebasket called pervasive developmental disorder, not otherwise specified, recognizing the fact that a lot of kids don't read the DSM and don't follow the rules, but you know that they have something similar. And then there were two other conditions, Rett syndrome and childhood disintegration disorder, which were very rare and which have kind of been put into DSM-5 and other. As a result of the research that went on, the DSM-5 committee recognized that really autism was a spectrum, and they decided pervasive developmental disorder was not a very good term because there's a lot of developmental disorders and they do all kind of cut across all walks of life, so that wasn't a terribly helpful name. So they decided to call it an autism spectrum disorder, and what they found was that at least if you look at the research, there really wasn't much difference between autism and Asperger's, and the PDD-NOS had gotten so broad as to basically be, the researchers didn't think it was being terribly useful. So they really tried to drill down to what they considered to be the most core features of autism, but recognize the fact that each of those core features had a spectrum of ways that it manifested itself. So, for instance, one of the core deficits in autism is persistent deficits of social communication or pragmatic language and interactions. And so it assumes not only do you have difficulty talking and communicating, but your interactions and your play show these deficits of reciprocity. It has to be apparent in multiple contexts, and it needs to be either apparent currently or evident in the past by history. And the reason that becomes important is because we've really developed a lot of interventions which really has changed the course of autism for a lot of kids. And I know as a doctor who sees those kinds of kids, I will see a child who's maybe 8 or 9 or 10 who's a little quirky, but really doesn't look like they would be autistic now. But then I look back to what the child was like at 2 or 3 or 4, and they did look like they met criteria for autism. They've had a lot of intervention, and so, or maybe just grew out of it, and so now they have a little bit less than they did before. So that history piece ends up being important. So the persistent deficits in social communication and interaction is a core feature, and the other core feature is restricted, repetitive patterns or behaviors or interests, again, apparent currently or by history. Each domain of impairment is given a mild symptom, which is why it's called an autism spectrum disorder. The symptoms, they try to organize them coherently, and since autism and intellectual disability...
I can't type and do that.
Say that again?
Hi, we're having some background noise. Could you please all hit *6? So we've had a phone in the background and a person who said she can't type and do that. So just help us out a little bit. This is a very low-tech, a way to convey information, so we need everyone's cooperation. Thank you so much. All right, Dr. Carlson, thank you.
So since autism and intellectual disability can co-occur, the autism symptoms have to be over and above what you would get with an intellectual disability. So let me just say a little bit about what social communication and interaction consists of. The first thing is the social-emotional reciprocity. This is the business about kids with autism, people with autism, have difficulty seeing something from somebody else's shoes. Can't stand in somebody else's shoes and look at a particular situation or recognize that that a person thinks differently, sees things differently from the way they do. They can't predict or understand another person's interaction, and they end up with a social approach that's kind of odd. Their back and forth conversation doesn't work because the kid with autism has trouble sharing interests. So, for instance, if they're interested in snow, they're going to be talking about all the snow that's happened in Buffalo. And everything that they do, the subject is going to come back to Buffalo. And even if you say, well, what do you want for lunch today? They might say, well, if I were in Buffalo and if I were working out there in the snow and let me tell you, it was really deep with the snow today. It's very difficult to get them off the topic of what they're interested in. Also, nonverbal communication that's used for social interaction. I was reading the other day that basically only 7% of communication is verbal. 93% of it is nonverbal. So you can't see me right now. I've got my hands clasped and my eyeballs are rolling and my hands are waving furiously. And so I'm doing all this nonverbal communication to my empty office, and you can't see it. But you can hear the tone in my voice, which I hope isn't too pedantic, which goes up and down as I try to emphasize different kinds of things. Those are sort of the nonverbal communication pieces, which autistic kids have a lot of difficulty understanding and interpreting. And so it makes their conversation pedantic. It means that they miss the fact that other people are being bored to death as they talk too much about snow, and their eyes are rolling and they're backing away and so forth. A kid with autism has trouble appreciating those things. As a result of this, kids with autism have trouble making and keeping friends. For a long time, we said they weren't interested in friends, and that's not true. Especially as kids get older, they very much want to fit in. They very much want to have friends. Unfortunately, these quirks that they have really are off-putting to other kids who pick up on it fairly readily and say, "Well, they're weird. They're really boring. I don't want to spend time with them." So you get a range, of course, from kids that are really not interested in other kids and really are very much in their own world and doing their own thing, to kids who would like to be able to be friends, but their other challenges make it difficult for them to do that. The second set of criteria address the restricted repetitive interests and behaviors, and those are things that subsume some language. So as a child with serious autism develops language, sometimes they'll go through a period of echolalia where the only thing they can do is repeat what somebody else says. Sometimes they never really are able to do more than that. Sometimes they'll outgrow it, but echolalia is considered stereotypic. Motor movements like the hand flapping and stereotypies, or use of objects like lining up toys or flipping lights on and on.
You're okay, Phil.
Stereotype behavior. Insistence on sameness. That was one of the core features that Leo Kanner originally recognized about the fact that with a child with autism, for them it's almost it's frightening for them when you change a direction or a route that you go in, or you change furniture around. It really causes a catastrophic response or a meltdown. The perseverative interests that are normal, abnormal in intensity or in focus. Sometimes the interest is in something weird, like I had a kid who was really stuck on hair dryers, and that's all she would talk about is hair dryers and all the bathrooms and hotels she'd been in, what different kind of hair dryers they had. To another kid who could have a perfectly normal interest, like a 10-year-old that I had who really liked sports, but that's all he would talk about was sports. So it's both the subject and the intensity of focus that makes a difference. And then another one, which people had recognized who studied autism for years but was never part of the criteria, and that was the sensory sensitivity. Very sensitive or indifferent or unusually preoccupied with reactions or sensory input. So I remember when I was a fellow, and Ed Ornick, who was a big researcher at UCLA, was having me observe a kid that he had in his lab. This child got really excited, and I didn't know why. Turned out he could hear a fire engine that was about 10 blocks away from where we were, and he picked up on that. On the other hand, Dr. Ornitz picked up a wastebasket and dropped it on the metal floor. I just about jumped out of my skin. This kid was oblivious to it. So you recognize that he really had some, both abnormal perceptions, that he was able to hear things that other kids wouldn't pay attention to really ignoring certain kinds of sensory input. So that sensory abnormality is really important. There are a lot of different qualifiers that I won't bore you with, but the fact is that the hope is that this comprehensive way of looking at autism will encompass the kids that really have a significant handicapping condition. Now, it has met with some resistance because people with Asperger's disorder felt that they had sort of something separate from people with high-functioning autism. And I have to tell you, as a clinician, I think Asperger's was able to convey something that autism spectrum doesn't convey. So I'm not necessarily, I understand and sympathize where the research is coming from, but as a clinician, I think it's helpful to have a vocabulary that patients understand. So I can understand a little bit what the upset is. Okay, so let's go on and talk a little bit about DSM-5's attention deficit hyperactivity disorder. Fortunately, not a lot of changes with that. A couple of important ones, though, and that is that as we've recognized the fact that ADHD is a developmental disorder that continues into adulthood, the criteria now try to encompass how that's important for adults. And so it used to be you couldn't make the diagnosis if there weren't some symptoms before the age of 7. Now it's you have to have symptoms before the age of 12. And that's because if you're seeing an adult, they're not going to be able to know whether they had problems before age 7. But if you say, were you in trouble in elementary school because you didn't get your homework done, or your teacher told you were talking too much or minding other people's business, there's a fighting chance they're going to remember elementary school. And the criteria try to get it a little bit out of the array of play and a little bit more to have some specifiers for work so that the criteria are more understandable for older adolescents and adults. We recognize the fact that you can outgrow the hyperactivity part. So if you used to be hyperactive and inattentive, and now you're only inattentive, you really shouldn't be given an inattentive presentation diagnosis. You actually have ADHD in partial. Let's talk about bipolar disorder and disruptive mood dysregulation disorder.
734-3349.
That problem arose unintended consequences of previous DSM. And the fact that something called rages or explosive outbursts, probably one of the most compelling problems, doesn't have a diagnostic home anywhere. Severe tantrums are present in almost 20% of preschool children, in 6% of school-age children. These are in a community sample, so these are not rare problems. And the fact is that we haven't had a good place to put these symptoms. They ended up getting called bipolar or mania for a variety of reasons. But the fact remains, we are recognizing the fact that it's really not true. What has happened, though, is because those symptoms got called mania, bipolar disorder diagnoses really increased enormously over the last 10 or 15 years. They went up like 7-fold in terms of inpatient diagnoses, 40-fold for outpatient diagnoses. And so the DSM-5 committee said, wait a minute, we can't have, it just doesn't make any sense that bipolar disorder is that common in kids. And so they went back and they looked at how this whole process evolved. And the people at NIMH started a body of research looking at whether or not there's a difference between well-defined manic episodes and chronic irritability with explosive outbursts. Lisa Luft is the person who's headed that research, and she called that chronic irritability with explosive outbursts severe mood dysregulation disorder. And so the DSM-5 committee basically did two things to try to correct this problem with the mania bipolar disorder. They made the diagnosis of mania more specific, more precise, and they identified episodes more clearly by saying that you had to have an abnormally and persistently elevated level of activity, energy, mood, or irritability for a week with other associated symptoms that have to be different from your usual behavior. That means that you don't take a child who develops the terrible twos and who continues to be terrible for the next decade and say that they have an episode of mania. That's not an episode. An episode has to have an onset and an offset. And so that's what the DSM-5 people tried to do in defining mania and bipolar disorder. And they sort of hijacked Dr. Liebenlotz's severe mood dysregulation disorder, tinkered it around a little bit, and developed this other diagnosis now called disruptive mood dysregulation disorder, which is defined by severe recurrent physical or verbal temper outbursts grossly out of proportion in intensity or duration to the provoking circumstances, apparent most of the day, every day, in more than one setting, not explained by mania or autism or depression. And again, it's the chronic irritability and explosive outbursts in multiple settings that define this condition. Oppositional defiant disorder, the kids who have disruptive mood dysregulation disorder, many of them have oppositional defiant disorder. But the rule that they developed is if you've got the chronic irritability, you get DMDD. The difference is an oppositional defiant kid is just fine, thank you very much, as long as you're doing what he wants. And he only becomes only has a temper tantrum if he doesn't get his way. That's different from a kid with disruptive mood dysregulation disorder who's just chronically grumpy all the time. A little kid that I saw described it as, I feel like my temperature, is like boiling water, not quite boiling water, 211 degrees. It doesn't take me much to boil over. Whereas an oppositional defiant disorder is plain just fine. You tell him to put away his toys, he doesn't want to do it, and then you get a temper tantrum. So that's kind of the difference between DMDD and oppositional defiant disorder. So it looks like I've sort of chattered on a little bit too long here, so let me be quiet now, and I guess you want to open the phone to questions, right?
Great. Thank you, Dr. Carlson. A very nice summary looking both longitudinally and more recently. And if you're willing to, identify where you're from and your first name, if you're so inclined, for your questions for Dr. Carlson. Go ahead.
Hi. Can you hear me?
Go ahead.
I'm from Fairfax, Virginia, and my name is Nicole. My question is on ODD. Is that a diagnosis that an adult can carry? I've sort of heard of ODD in the context of kids, but you never hear of adults that have ODD. Do people?
And you know what? They need to have it. You're absolutely right. But just like ADHD continues to adulthood, ODD probably does, but it is not considered an adult diagnosis. It's actually a very interesting condition. When it was born in 1980, people thought it was a throwaway diagnosis. You're calling my kid a brat. What kind of a diagnosis is this? It turns out that it has two important components. One component is a mood component, irritable, loses temper, easily provoked. And it also has another component, which is kind of a more spiteful, vindictive, who died and made you queen sort of attitude, what we call it in Long Island. It's got those two components. And it really underlies a lot of other adult disorders. I wish we had it as a diagnosis in adults, but we don't.
So what happens to a kid who becomes an adult who's diagnosed with ODD?
Well, it depends. If he's got more of those irritable, loses temper symptoms, he actually ends up more likely to have a depression or an anxiety disorder. Sometimes those temper tantrums attenuate, but the longitudinal follow-up would suggest that it's that mood piece that ends up being the more compelling part. The more mean parts, called the headstrong part, the spiteful, vindictive, who died made you queen attitude part, often ends up developing into more conduct problems, rule-breaking problems, and in the more severe cases, even antisocial behavior.
I can keep going with
I can also say, having had a child who had ADHD and oppositional defiant disorder, those things go together like the horse and carriage. And the reason that they go together is because that the outburst piece is often part of the mood regulation abnormality that occurs in ADHD. I didn't go through all the criteria because I didn't have time, but think of ADHD criteria as spelling out hide, because that's what you want to do with a kid with ADHD when he comes over to your house. So it's hyperactivity, impulsivity, distractibility and disorganization, and emotional lability. And that emotional lability often leads you to the temper tantrums. The kid's mad, and he can't control it, and so you get an explosive outburst. And that's one of the reasons that it ended up getting called mania, because the emotional lability part got out of the criteria for hyperactivity, ADHD, and the only place for it to go was into mania. But a lot of those kids have ADD and explosive outbursts that are part of the mood lability. As they outgrow their ADHD, or as it attenuates, or they get treated for it, that also gets better.
What do you suggest as a medication to distinguish between bipolar and DMDD?
You're sounding too far away. I didn't quite hear what you said.
How are they distinguished between the medications?
Oh, what's the difference between the medication treatments? Is that what you said for bipolar and DMDD?
Yes.
Yes, okay. That's also a very good question. You understand that in order to answer that question, DMDD has to be around long enough for somebody to do a treatment trial in order for me to really be able to answer that question as well as I would like to be able to answer it. But here's my thinking on it. I give a lot of lectures on the subject, and so I'll give you my fast and dirty here. Just as I said to the other lady that the emotional lability piece is part of the ADHD, it's the irritability piece there. What you often end up doing is seeing if ADHD is there. If ADHD is there, you try to treat it like it's ADHD. Many times, many times, the symptoms really get better enough that you don't have to do anything else. When they don't, you have a variety of choices, and those choices include things like the alpha agonists, like clonidine and guanfacine, and I don't know if I'm supposed to use generic or brand names when I do this, but like Intunib or Capve, or as I say, the generic names are clonidine and guanfacine, so that type of medication. Or the atypical antipsychotics, like risperidone or aripiprazole or quetiapine, which is Risperdal, Abilify, and Seroquel. So those kinds of medications. Sometimes even mood stabilizers like divalproex or lithium can be helpful. But you really need to stabilize or get the ADHD piece treated first before you do that. There's another emerging body of research that's coming out of Dr. Liebenluft's lab and other places that say that there's also an anxiety component sometimes to the disruptive mood dysregulation disorder. And so there are some treatment trials going on now saying, okay, well, if this ODD thing or DMDD thing ends up with being continuous with anxiety or depression, what would happen if we treated that with an SSRI, like fluoxetine or Prozac or sertraline or Zoloft, or, the SSRIs that are used to treat depression or anxiety. I'm not aware of any results of those trials yet, but those are the kinds of things that get used. How is that different from bipolar disorder? Quite frankly, if you really have somebody who's got manic depressive illness, you don't treat them with a stimulant. You're treating them with the mood stabilizers and or the atypicals. So some of that is a common denominator. The major thing is you don't treat them, somebody with a manic episode, you don't treat them with a stimulant.
Very good. Thank you.
Hi, this is Lauren from New Jersey. I'm wondering how you could address concerns that the elimination of Asperger's syndrome from the DSM-4 and just putting everything under the autism spectrum disorder in the DSM-5 is going to lessen services, whether they're in the educational field or services for people with developmental disabilities. I've heard a lot of concerns about that.
I'm actually less concerned about it eliminating services for the Asperger kids, who are usually significantly impaired with their social, emotional reciprocity and stereotyped interests. It's the PDD-NOS, it's the sort of wastebasket kids that are really the ones that don't get covered easily in these criteria. Part of the reason that the Asperger business came up was that initially the most important symptom of autism, I think I'm saying this right, was the language, the absence of language, the severe language delay. If language developed, it was peculiar in its tone and subject matter and so forth. Many kids that had Asperger's, that got called Asperger's, had that in the beginning, and they had it before the age of 3. And if you followed the Asperger rules, they actually had autism. Why their language developed so that it was better, I don't know. I mean, there's a lot of things we don't know about that condition. But there are some kids with Asperger's disorder that if they're talking to an adult, don't seem like they've got abnormal language at all. In fact, if you do language testing on them, it's one of the things that drives me up a wall, is that the school districts will do language testing like a SELF or one of the other structural language tests, and the kids look fine. And so then they don't qualify for speech and language. It's their pragmatic language, their language in a social context, that ends up being impaired. So part of the business with Asperger's disorder is if they followed the rules, those kids actually had autism. That said, I agree from a practical standpoint. There is a difference between the kids who have structural language deficits and the kids who only have pragmatic language deficits. And so the current DSM-5 criteria have ways of tinkering around with the qualifiers and saying structural language or not structural language deficits. I just feel that when I see a patient in my office and the kid is really in trouble because of his pragmatic language and his stereotyped interests, I can say to him, or I can say to the parent, look up what you can find about Asperger's disorder and see if that fits the bill for your child. Whereas if I say, look up and see what you can about autism and see if it doesn't fit it as well. So from a practical communicative standpoint, I miss Asperger's disorder, but I do understand the research that underpins it, and I guess it really depends on your school district what they give services for. Knock wood, I think I'm lucky on Long Island. I've been here long enough so that I've worked with enough school districts. We don't have kids that are eliminated because of that. The kids that get short shrift, as I say, are the ones that don't have quite enough symptoms to make it all the way into the autism spectrum disorder criteria.
Right, and the jury's still out as to whether or not, Asperger's syndrome and high-functioning autism are even separate diagnoses.
The autism experts would tell you that the jury is not out and that they're the same. I won't. This is not. I'm a bipolar and ADHD and DMDD expert. I won't get into the autism fights. But at least according to Kathy Lord and Sue Sweeto, who I've heard talk multiple times about this, they go on with some degree of conviction that the research really would say that when all is said and done, the genetics, the biology, the outcomes, et cetera, aren't that different.
Right. Okay. Thank you.
Mm-hmm.
Hey, it's Phil from Denver. Can you hear me?
Yep.
Go ahead, Phil.
Okay, quick question for you. Getting back more in alignment with the whole DMDD/bipolar, debates. What's the long-term outcome and outlook, for kids? Let's say you've got a kid that is, truly bipolar. Does that diagnosis typically stay with them, into adulthood? And is there a difference in the way DMDD presents as children grow up and enter the adult years?
I think those are both very good questions. The bipolar business, you understand that these are religious wars you're talking about. That people have very different viewpoints about what bipolar disorder is. When I've written about it, I call it liberal and conservative, and I mean it that way because it's descriptive. I know what my political persuasions are, but I guess I'm humble enough to say I don't know if I'm absolutely right. I just know what I believe. And so for bipolar disorder, if you use very strict mania criteria and you've got somebody who is pretty well, behaved and developed and so forth and so on, and at the age of 13 develops their first manic episode, and then they're okay, and then they develop a depressive episode, and they're okay. They have pretty classical manic depressive illness. And that illness is pretty well continuous with adult bipolar disorder, and it has a range of outcomes. And the range of outcomes are basically 40% of those people will do pretty well. Another 40% of them will continue to have significant episodes and will be somewhat impaired but will be functional. And about 20% of them will be chronically ill. Boris Bermaher and his group at Pittsburgh have recently published a paper using a statistical procedure called latent class analysis, and those findings are very similar to follow-up studies that we've done in adults. So if you've got a fairly classical presentation, then yes, it's continuous. If you've gotten the diagnosis because your child was 4 and he was severely hyperactive and having explosive outbursts and so forth and so on, and somebody said, well, he's got this prepubertal phenotype of bipolar disorder, the data would say that child is not going to grow up to have manic depressive illness. The child may grow up to have other problems, but he's not going to grow up to have manic depressive illness. It is a serious problem. I don't think anybody says one thing is more serious than the other. And the reason the DMDD got sort of invented was because people wanted to be able to have a way of looking at this down the road a piece. But as I said to the first caller, because this thing has only fairly recently been developed, even Dr. Liebenluft's severe mood dysregulation disorder is only about 10 years old. Nobody has really done actual follow-up studies. They've done follow-back studies or imputed studies, and they've sort of done predicted studies, and that's where I said that they've sort of come up with the fact that DMDD may map more onto depression and anxiety disorders than anything else. But it just hasn't been around long enough, nor is your government going to pay for the research, because right now they don't care about doing longitudinal studies. So I'm not sure how we're going to answer that question in 10 years from now. But what we really need to do is have a cohort of those kids and, follow them up at 2 years, 4 years, 8 years, 10 years, 12 years, and find out what happens to the condition.
Okay, that makes sense. And as you said, longitudinally looking at it, those kids may not actually grow up to, experience manic depressiveness in adulthood, but you said they might experience, other significant concerns. And then later in the conversation, you also referenced, anxiety or depression. Are those where those DMDD kids, in your opinion, probably are going to funnel to have chronic depression and anxiety issues, or are there other things for me to worry about moving forward?
Moving forward. Well, I think, again, a lot of it depends, and now you're getting opinion. This isn't data. This is my opinion. Insofar as you've got a lot of the kids who have DMDD actually have attention deficit disorder with mood regulation problems, as I said, some of those things are, because it's a developmental disorder, attenuate with time. And if you look at the outcome of ADHD, for instance, you've got a significant number of adults that are continuing to have the symptoms, but some of them are doing okay with them. I like to call it the square peg has found a square hole. And so, you become a good salesman, or you become a good flight control. I'm trying to think of the dads that I know have had that, a flight controller, or my son is a nurse, actually. So, there's different things that you can become and that you cope with. So, but there are some people that whether they have a worse form of it or have other kinds of issues, maybe learning disabilities or whatever, they don't outgrow it so well. And so the more other things that you have, the more balls and chains you have around your feet that become, sort of more impediments when you grow up. So I guess what I'm saying is, speaking of juries being out, the jury is out in terms of the outcomes of DMDD because we don't know exactly what it is. But insofar as a lot of it is probably ADHD with some oppositional defiant symptoms, we do know what the outcome of that is.
Okay, that makes sense. Thanks for your time.
Mm-hmm.
Another question for Dr. Carlson. Dr. Carlson, these are good questions, aren't they?
They are very good questions. It's fun for me to hear what's on people's minds. When you asked me to do this, there's a lot of stuff I could have talked about. I talked about my favorite topics. But people didn't know that's what I was going to talk about when they listen to this. So I'm figuring, okay, well that's what's on their mind too. It's good prediction.
Exactly.
Yeah,
NAMI members ask good questions on these calls. Everybody's impressed by that. We have time for a few more questions before we close for today.
This is Alicia from Montana.
Go ahead.
I'm curious. I know I am in my 60s. I've learned my first diagnosis was at 14. But as time goes on, I seem to get more diagnoses. Is that either because they are learning things differently? So back in the Stone Age, it was considered this, and now it's that?
Yeah, one diagnosis, idiocy or not, right?
Or does it happen that living with one form of mental illness might bring on a different one?
Well, you've got there may be a couple of different issues going on. First of all, even though we have for the last since DSM-3 tried very hard to come up with criteria and reliable diagnoses, and by reliable what I mean is that three different psychiatrists can look at the same bunch of symptoms and come up to the same conclusion. Even though we try to do that, the whole bipolar business that I was just talking about is a fine example of the fact that it doesn't always work, because you've got the liberals and the conservatives looking at the same thing and drawing different conclusions. And that isn't because one is stupid and one is smart, or one is venal and one isn't, or any of those things. They add up the figures and they call it something different. And so it may be that partially explains what it is. There are things that do evolve over time. Like autism, for instance. I have known a number of kids with autism, and they look like they had pretty classic autism when they were little. And now, as young adolescents, they look like they have social phobia, social anxiety disorder. And, if I hadn't looked back at their previous history, I never would have guessed that there had been autism there. Now, did they change their diagnosis? Or did it evolve? Or did they develop out of the language piece? Or, in fact, what the kids will tell you is I don't know what to say to other people, and that makes me feel very shy. I don't know. I can only tell you that there looks like a difference. And so people who do research in the field talk about heterotypic and homotypic outcomes. And homotypic means that depression is depression at 15, 30, 45, 60, 80. Depression is that depression is homotypic. Or it can be heterotypic, like what it was I was just talking about. So some of those things do evolve. It's also true you can develop other things. And so to talk about anxiety again, kids with anxiety and depression are kissing cousins, and it is not infrequent that kids with anxiety will develop depression. It is not uncommon for kids with ADHD to develop depression. Now, is that because they have been going through elementary school frustrated by the fact that they keep being told to sit down and shut up, and they're not getting their work done, and what's wrong with them, and blah, 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 and they end up being demoralized? Or is there some genetic continuity between ADHD and depression? I don't know. I can only tell you that there's a lot of times that children with ADHD will develop something else as time goes along. So there are certain things that kind of go together. It's not, zebras don't totally change their stripes, but yeah, there can be all of those different things that are going on.
Thank you.
But I wasn't kidding when I told you that, in DSM-2 there were like 100 different diagnoses, and now like there's 300 different diagnoses. So we started parsing the pie a little bit more than we did before too.
Thank you.
Dr. Carlson, near the end of the call, I typically ask our expert if they have a favorite article, book, chapter, or reference, and then my faithful teammate Emily sometimes appends it to the recording of our call. Do you have a favorite discussion piece of the history of DSM or the changes in diagnosis in DSM-5 for children and adolescent, or would you just go to Dr. Liebenluft's research?
Well, I think it depends on what you're talking about. If you're talking about the history, I'd have to look that up. The person that really talks about it are the people who are the heads of the DSM-5 committee. Daryl Regier gives a really nice lecture on the subject, and I borrowed some of the beginning of my talk from Daryl's thing, and I can find a reference to that if you want the history of it. If you want the bipolar DMDD business, I actually have a nice summary article that was in a psychology journal that was published in March that I can give you, but that only talks about the different viewpoints of bipolar disorder and the DMDD piece. The autism business, again, is a completely different literature there. So I would, if you'd like, I can come up with some summary articles for you.
That would be just wonderful. Because, you've thought a lot about this. You've been on these committees. You're reviewing the research in a sophisticated way. And, we don't have that resource very often as people think about how do we organize our thinking about the different diagnoses in terms of...
It's at the end of the day, diagnoses, as I think I said, is we're trying to communicate in a way. So if I say autism to you, you conjure up an image in your mind, which hopefully is what autism is, just like if I say... book to you, you conjure up something in your mind that's presumably not a peanut butter sandwich or a glass of beer. So, we need to have our communication be together. That said, we're talking about people with a condition, and so you've got the parts of the condition that are the pathological parts, the things that allow you to say it's autism, and then you have the pathoplastic parts, the individual parts that say, as one person says, if you've seen one kid with autism, you've seen one kid with autism. They're not cookie cutters. They're not all alike. And that's the fun part of the condition, but it's also the part that makes diagnosis complicated.
And humbling.
Just like parenthood.
Well, Dr. Carlson, I think we really enjoyed this call. I certainly did. I learned some things that I hadn't really thought about. So I know I've been asking everybody to be on mute. I'm now going to ask you to unmute yourself and sing out your best NAMI thank you to Dr. Gabrielle Carlson, who's doing a lot of interesting work and was kind enough to give us an hour of her best effort.
It was my pleasure.
Thank you, Dr. Carlson.
Thank you, guys. Have a nice Thanksgiving. Bye-bye.
Thank you.
Thank you
so much.
It was wonderful. Thank you.
All right. Thanks, everybody.
Okay, and I'll try to email those articles to Emily, okay?
That's wonderful. Thanks again. Very much appreciated.
Okay, bye-bye.
Bye-bye.